Welcome to Parkinson's Resource Organization's Together in Parkinson's podcast. Join us as we delve into the latest medical treatments, share valuable insights on care, and discuss practical strategies for navigating life with Parkinson's. If you appreciate the insights, stories, and conversations we share, we invite you to support our podcast. Your donations help us continue creating quality programming and bring you the topics you most want to know about. Every contribution, no matter how small, makes a difference.
Well, hello, and thank you for joining us today for another episode of Together in Parkinson's. Today we are discussing Parkinson's, hallucinations, and delusions. Joining us is Dr. John Legge, a board-certified neurologist with fellowship training in movement disorders who works out of Eisenhower Medical Center in Palm Springs. Welcome, Dr. Legge. It is great to have you here today.
Thank you, Eileen. It's always a pleasure. Thank you for having me.
Well, we've got a tricky topic to discuss today, so let's jump straight in. Sometimes called Parkinson's psychosis, hallucinations and delusions affect anywhere from 20 to 40% of Parkinson's patients, depending on what statistics you're looking at. What can you tell us about that number? Who is affected, and when should people expect to potentially see this in their disease course?
That's a great question. And studies vary, as you say, but generally speaking, I quote roughly about half of patients are affected, can be affected by some degrees of Parkinson's psychosis. Psychosis itself is a depth of topic to define itself, but those phenomenon that are disturbing and psychotic in origin, as we say, it's about half of patients, and there are certain risk factors. One of the top is disease progression and how far a patient is along the disease course with Parkinson's. The longer standing and more severe the Parkinson symptoms are, particularly cognitive symptoms, that being thinking and memory, focusing and visual spatial reasoning. When we start to see more of those issues in terms of cognitive impairment, which itself tends to happen later in the disease, that's when the risk of hallucination can increase. Psychosis, I should say. And it can also, to some extent, also depend on the amount of medication and the type of medications people are taking. And so we consider a variety of different risk factors when we're evaluating someone's risk of developing Parkinson's psychosis.
Okay. So let's actually pause here and talk about what Parkinson's psychosis looks like. What do hallucinations and delusions look and sound like for both the caregivers and for the people experiencing them?
Indeed. So it's, I like to try and break it up into different portions. So psychosis is more or less an umbrella term under which there's different features that can happen. Frequently people think about hallucinations. And so that is very classic with Parkinson's, as well as Lewy body. Patients can experience pretty well-formed hallucinations, and that can be in the form of a classic can be insects, bugs, perhaps small animals like snakes or mice, or extra animals in the house, maybe an extra cat or extra dog. So you can see things. Sometimes you can hear or feel things, tactile hallucinations, someone touching something in your hand, perhaps. So those are more hallucinations. There are delusions, which are more, fixed false beliefs. So, frequently there can be phenomenon where patients may mistake loved ones or caregivers with, different people, or think that they may be an imposter or perhaps a duplicate of that person. That can even happen with surroundings, that the room or house or apartment can look the same, but it's not quite the same. It's been replicated. So certain fixed false beliefs, or even paranoia, which is persistence, kind of fear, suspicions, and they can vary, and they can wax and wane, and they can have more than one. You can have features of all of them. And so that itself kind of characterizes Parkinson's psychosis, a combination of hallucinations, seeing or hearing, delusions, kind of fixed false beliefs, or the paranoia, those kind of suspicions and fears.
Yeah, and I know sometimes people even report that they smell something burning when there's nothing burning, when the caregiver can confirm there's nothing burning or something like that. So there's the visual, there's the auditory, there's even that olfactory as well as the
The
tactile, which you mentioned, and
yeah,
maybe tasting something,
yes, yeah,
bitterness that's not there.
indeed, indeed, sensory phenomenon, if you will. Yeah.
So what causes a person to develop these symptoms?
Well, we think it's, again, it involves many different circuits in the brain. And I think predominantly it involves a lot of the higher order thinking circuits that argue for when they are not working well, there can be some degree of cognitive impairment, forgetfulness, difficulty focusing or coming up with conversations, words, and things. So it's higher order thinking circuits, and it's also a lot of dopamine circuits. Okay. So that's where a lot of the medicines work, the carbidopa, levodopa type of medications, others as well, amantadine, dopamine agonists like Requip, Ropenetrol, or Mirapex, some of the patches like Nupro, other meds can work on those dopamine circuits. And when you have, as the Parkinson advances, those circuits, so to speak, break down. And when they're not working well, patients become more susceptible to having intrusions of false thoughts that manifest with those sensory hallucinations, the paranoias or delusions. That happens again, typically when there is cognitive impairment, more later in the disease, and when there may be certain medicines on board or higher amounts of dopamine medications.
Yeah. So the progression and the deterioration of those dopamine receptors in your brain combined with the increasing level of medications, basically there's a haywire effect to a certain degree in the brain.
That's a good way of putting it. Yeah.
So another aspect, I'm not sure if this necessarily qualifies as hallucinations and delusions, but sometimes people report generalized fear or anxiety to a point that is something they've never experienced before. Do you see that as a separate symptom from Parkinson's psychosis, and would you treat it differently?
Yes, I would see that as a separate symptom. Now, I will say that, as I use the word fear and suspicion in my definition of paranoia, which can be a feature of the Parkinson psychosis. But so in and of itself, Parkinson can cause 40-50% of patients to have mood changes, depression, perhaps sadness, feelings of guilt, or anxiety, kind of agitation, or, heightened levels of, kind of alertness and kind of panic. And oftentimes they can commingle. You can have both of them together. That can depend on medication response. Oftentimes patients, when their medicines may be wearing off, they may feel more anxiety building. That I tend to think of differently too, if patients have a history of anxiety, and then maybe Parkinson came on later. If, however, that anxiety is overwhelming with panic attacks, that's a separate thing too. But if we see that fear, anxiety mixed with suspicions, mixed with seeing things, shadows, bugs at times, that's when I start to think about it and would approach it more from the psychosis approach versus the mood disorder approach.
Yeah. I mean, it's interesting to talk about Parkinson's as a mood disorder because I think there is a general misconception in the wider public that Parkinson's is a movement disorder, which is how it's characterized for sure. And that the tremors and the dyskinesia and the muscle stiffness and the balance issues are the entire disease course. And it often catches people off guards, both family and friends, but also the person with Parkinson's when they do experience that those extreme mood swings, the depression, the anxiety, and then of course what we're talking about today, which is the psychosis.
Absolutely. And, to your point, catching people off guard, there's also, a reluctance to discuss some of these things we're talking about, right? So, again, I appreciate you having this important discussion. This is important. April's Parkinson Awareness Month, and the Parkinson Resource Organization is doing a lot of good. And this conversation, we see people generally may not discuss this unless they're asked about it. And so that is to say, people are, patients may be having these feelings or experiencing these things and be embarrassed to discuss it. So, being open about it. And when I talk with patients, they know this is going to be asked, it's because it's important.
So that was actually my next question, Dr. Legge, is kind of a two-parter. How should caregivers respond or act when they witness this behavior in their loved ones? And also, how can patients bring this to their doctor? What should they expect of that conversation? I think sometimes when you experience delusions, for example, and afterwards, there was no one standing in that corner, you worry that you're going to end up in the hospital in rubber socks. So how can we dispel a little bit of the anxiety around even talking about this? And how can caregivers in particular be part of that?
Yes. So, I think early recognition is important, because this doesn't go, these symptoms don't start and then zoom, develop. Generally speaking, it starts off low and slow. There's mild things, hints of, flashes that you feel someone's in the room with you when you're alone before, and you see spots maybe start to move before you see well-formed animals or people, so there's mild hints that things happen. So I think early recognition is important. And, knowing that this impacts the patient, the caregiver, the family, loved ones, together, then it needs to be kind of an approach to cope together. And, early on, patients generally maintain what we call insight. They recognize that these are unreal, this is not, and we can talk through that. So, generally you respond. I approach kind of conservatively at first to talk through it, be open about it, and ask. This tends to happen perhaps more in the early hours of the day or late in the evening. So being kind of tuned into that patient's rhythm, which families, are in tune with it. When you take certain medications may impact, being attuned to that, talking through things at first. I always try and maintain an approach that would be you're being calm, you talk through it, you try and redirect. So, if you can if you can't convince someone early and easy that this isn't happening, if it's persistent in generating confrontation, then it's not worth really, trying to really force someone to recognize that's not, because that's just going to feed anxiety. So I think then trying to redirect to something more familiar, more calm, more structured. And then maintaining that rhythm, as I mentioned that word earlier, a rhythm is that we know it is more important, in more advanced cases of any, neurologic problem, to maintain more structure with medicines, meal time, exercise time. If you do the best in the morning, then you're planning kind of activities. So you're maintaining structured familiarity environments. You've got a calm approach, a redirecting approach. You're trying to identify things early. But truly, if it needs to be that you can't cope together conservatively, then we make medication adjustments and may bring different things on board.
It's interesting that you talk about the rhythm of the day for the patient and building that structure, because that can also be really helpful for anxiety and depression, which we just referenced, that sometimes knowing exactly what comes next in the day, even if you don't want to do it, you do it anyway. And that does have the mood improvement. I know
Yes.
I spoke with one constituent once whose their loved one's delusion was basically that there's a cure for Parkinson's and that their loved one hasn't called the doctor yet. And so they'd say, oh, we have to call you got to make the call. Like, they're going to be able to solve this. And rather than kind of going through, no, there's actually not a cure for Parkinson's, the way that loved one handled it was say, yep, actually I put a call into them and we're going to talk to them tomorrow. And so just repeating that conversation over, actually, we're going to talk to them about it tomorrow. And so it does that exact redirection of calming them down in the moment and not necessarily having to go through that almost painful re-awareness of, no, there's still not a cure for Parkinson's.
Right.
Another thing that struck me while you're talking, and I will not ask you to make a clinical connection here, but we know that night terrors can be an early symptom of Parkinson's. And the way you are describing these hallucinations and delusions sounds a lot like the way people describe night terrors. So kind of an interesting bookend on the disease progression. It would be, just throwing this out there for the researchers who might be listening, it would be really interesting to see a study on whether people who experience delusions later in Parkinson's also experience night terrors early in Parkinson's. So Fox Foundation, if you're listening, get on it. So you mentioned also that there are some medication interventions for hallucinations and delusions. Can you talk us through what that looks like?
Yeah. Well, I think many times I think of an approach of less is more is better. So first, you want to try and look at what current carbidopa, levodopa, dopamine medicine, amantadine, dopamine agonist, if someone's taking, something for restless, like you got to look at the medication profile first. And if you can reduce or adjust some of the upfront, the Parkinson medications appropriate, that of course has to be balanced with, if you're reducing things, this may impact movement symptoms. So, you have to be kind of thoughtful about that. And then of course, if there are specific medications that can be used to help Parkinson related psychosis. So the only currently FDA, and I should say as in disclosure, I don't receive any, contribution from companies. So this is not by any means an endorsement, but in just listing the medications that we have on the market right now, pimavanserin or Nuplazid is the only FDA approved medication for Parkinson related psychosis. And it's quite an effective tool in the toolbox. It can be a little slow up front to start working. And there can be some coverage barriers and things like that because it's relatively new and things, but it's a good tool in the toolbox. There's other medications, frequently you'll see clozaril or clozapine, which has evidence to help Parkinson's psychosis. In lower doses, it can be effective. And then frequently used, but it's admittedly less evidence-based, is a medication called quetiapine or Seroquel. And that's a tool in the toolbox for many, many years. So generally, again, you want to try and adjust if you can balance these medicines for the Parkinson first, reduce or adjust while balancing the movement symptoms, and then you kind of consider adding on board an additional medicine dedicated for those symptoms if you need it.
And are there any antipsychotic medications that should not be used if you're on other Parkinson's medications?
That's a wonderful question. Thank you. Yes. Really, those only three that I listed are the ones that are safe because, I think it important, as we talked about dopamine, one mention is that dopamine is important for motor control. It's gasoline for the motor engine, the motor circuit, which is why if you're not having enough dopamine, you can get stiff, slow, or tremor. But it's also very important for mood regulation and sensory regulation, so to speak. So this dysregulation of these circuits can impact the development of the hallucination. So the medicines the unsafe antipsychotics, that they very much impact the dopamine circuits in a negative way that can greatly worsen thinking and motor symptoms because they block the activity, so to speak, of the carbidopa levodopa. So that can cause major eruption of symptoms or stiffening or freezing. So pimavanserin does not work on dopamine, number one, but it is an antipsychotic. Clozaril and quetiapine are the only real safe antipsychotics. Others are not safe to use, and that would be Zyprexa, Abilify, Haldol, some of the others. And hospitals, the reason this is a very important question is this can be, the case when someone's admitted to the hospital. If there's a disturbance in the mood, agitation, goodness, if an antipsychotic gets given, that could be a concern, right? So that's an important topic.
So it's very important to our listeners and watchers that if you are admitted to the hospital, or if your loved one is admitted to the hospital for any reason, that everyone who is involved in their treatment is aware that they have a Parkinson's diagnosis and of any Parkinson's medications that they are on before any care is administered, which is one we'll just keep hammering home. I think it's also worth mentioning that there is a type of Parkinsonism that is drug-induced, and that is connected to long-term use of antipsychotic medications. Now, that's different from what we're talking about today, the delusions and psychosis, but there is a Parkinsonism that is triggered by the long-term use of some other antipsychotics on the market.
Absolutely. And in fact, the use of those medicines causing drug-induced Parkinsonism can oftentimes lead to the development of Parkinson's disease. So, because again, those medicines disturb dopamine circuits.
Maybe, Dr. Legge, you'd be willing to give us a quick lesson on why it is so hard to deliver medication to the brain. Now, I know that's kind of off our exact topic today, but it's, there's the blood-brain barrier, and there's a lot of, what we're talking about with antipsychotic medications for example, in the way they solve one problem, but they might lead to another. What is it about the brain that is so challenging to treat?
That's a fascinating question. I think number one is the brain is what we call in other body tissues or such, reproductive tissues, for instance, ovaries, testicles, are privileged spaces. So they're kind of separated from the body, and you have to go through checkpoints to get into them. So that the BBB, the blood-brain barrier, is one. When someone takes carbidopa, levodopa, 25/100 milligram, if you just take 100 milligrams of levodopa, let's say 1 milligram absorbs. When you take carbidopa, levodopa together, 10 milligram absorbs. So it increases the absorption or penetration into the brain by 10 times, but you're going from 1 milligram to 10. So it's difficult to get access to that space. And when you do get access to it, there's fundamentally a variety of different receptors in the brain. Generally speaking, there's ones that excite the brain and ones that inhibit the brain, that increase brain function or more slow down brain function, involving serotonin and dopamine and other chemicals. But that crossover and spillage makes some of the medications non-selective, and it can hit different types of receptors among the dopamine or serotonin or what have you. But those receptors are not just in the brain, they're also in the gut, in the blood vessels, in the heart. So in order to get sufficient doses to penetrate in the brain, so to speak, you may be causing a lot of body-wide side effect, So it is an issue of penetration, receptors, and then a lot of the medicines are tough to design to target just this particular circuit of the brain, without causing other untoward effects. You're just getting this specific effect. So that is a feat of pharmacological chemistry, with the drug research and development is very challenging. So there's interesting things, using ultrasound waves and bubbles to shake open spaces to allow little air bubbles with, medicine trapped inside to penetrate through before the blood-brain barrier kind of closes back. There's new approaches they're trying. So
that's fascinating. I didn't know about that one.
Yeah.
Well, we've talked about a few treatments for Parkinson's, psychosis, delusions, and hallucinations. We've talked about redirection on the side of the caregiver. We've talked about some medication approaches. Realistically, what should people expect when hallucinations and delusions enter their disease progression, what should the family expect? And what are the outcomes of these treatments? Is there an effective stop to this?
So that's a great question. It's different family to family, patient to patient, but I think the approach is to dispel the stigma. Let's talk about it. Let's approach this from a cope together perspective. This is not just the patient to keep inside. This is an experience that impacts them and the family and the care team. Number one, cope together. Number two, early identification, so we can start making changes up front if that needs to be medication adjustment. That also gives skills early to start learning those rhythms we talked about, the patterns, start doing early reinforcement of day activities. Additionally, then, you start approaching those non-medication strategies once the hallucinations, delusions begin.